Aloha, everybody. Welcome to our Pasifika Grand Rounds. Today, we're delighted to have Dr. Raynald Samoa from City of Hope. He's an assistant professor there. He is both an adult and pediatric endocrinologist, and today he's going to be talking to us about gender affirming care for pediatric patients. Welcome, Ray.
Thank you, thank you. Oh, last week I made associate, so I don't know if that meant.
Okay, you got to update your signature title because I
I
just saw
know,
assistant.
I know,
Congratulations.
right? I totally am so late on that. Thank you so
That's a
much.
huge accomplishment, everybody. We should all
I
be
know.
sending Ray our
Right?
aloha and congratulations.
Thank you. Usually you're not gray haired by the time you get it, but thanks. All right. So I'm going in now. Yeah. Thanks, everybody. Uh, let me see. I just wanted to start with a quick land acknowledgement. I'm presenting from Southern California, which is the original stewards of the land were the Gabrielino and Tongva tribes. Um, and so we're doing more should be done to sort of bring them back their existence and their impact. Um, Disclosures, I have no potential conflicts of interest to report. The viewpoints in the presentation are my own, and they don't reflect any of the organizations I'm affiliated with. So our objectives today are relatively simple. It's to understand our role as physicians in health equity, introduce concepts of gender affirming care and endocrinology, and then also to stimulate discussion revolving the topic so that we optimize the quality of the care we deliver to our patients and community. Um, so, um, as a member of the Healing Association of Pacific Islander Physicians, um, one of the reasons why the group exists is for us to advocate. And so there are many different roles for physicians, being that the Pacifica Grand Rounds has a medical focus, especially towards physicians and other care providers, um, that there's many roles for physicians to play when it comes to health equity. It can take the form of care delivery. It can happen in regards to research, as well as our advocacy and our ability to change our environments. Um, so the quick definition of health equity is that everyone has a fair and just opportunity to be as healthy as possible. And so trying to remove obstacles that get in the way of people being healthy, such as poverty, discrimination, and other things that leave us in a state of powerlessness, um, need to be addressed and assessed. So, one of the large reasons why I chose the German gender affirming care to speak on is that the current health disparity that exists for trans patients. Um, and so, health disparity is a particular type of health difference that is linked to some type of characteristic that's generally inherent, but sometimes not, that produces socioeconomic and environmental disadvantage. Um, and these disparities are systematic, which means that they particularly happen systematically to a certain group. And in this particular case, when we're talking about those who are systematically uh, biased against due to their gender identity. So you've probably seen this slide. It's made its way around. Um, when you're talking about equity, you have to speak about reality and equality as well. Reality is that some people have advantages, and that produces some type of disparity. Equality is when we believe that everyone benefits from the same supports, and then equity is everyone gets the support they need, um, which is an entirely different concept. So, gender affirming care delivery. So, I speak to gender affirming care delivery because it falls within our wheelhouse. I'm a clinical endocrinologist. I do both adults and pediatric populations. I'm a Pacific Islander endocrinologist. I believe I won't be the only one on the, well, I'm the only one on the continent for the time being. Um, I'm also a member of the LGBTQ community. I'm also a queer researcher, which allows me to to give a different perspective when it comes to providing gender affirming care. Um, so the reason why this topic is a hot button issue is that there's so much legislation currently in the nation that is producing a large disparity when it comes to the health of our youth. There's gender affirming care bans impacting youth in a number of states. As you can see on the slide, all the ones in the dark red have laws that have passed already that ban gender affirming care. And yeah, the orange are those where the laws of gender affirming care bans are being considered. And so one of the reasons I also wanted to speak on this. One is not to be political. Our job in Happy and the other groups that are doing is not to produce political agendas. In this role, what we do want to do is eliminate health disparities. And we'll talk later on as to what these disparities are and how we can minimize them. And so this is purely from a being an advocate for patient care as a physician that I speak to gender affirming care. Um, so, why is it a big deal? In one study in 2020, where they were able to sort of survey 372 transgender youth, 86% reported they have considered suicide, and 56 reported that they have attempted suicide. And I know some of us might believe that this is inherent in being transgender, that these high rates of suicidal ideation as well as suicide attempts are from the fact that these youth are transgender. But there is evidence that speaks against it, and we'll talk about that in a little bit as well. But what that does bring forth is that a large, there are youth in our communities and our population that are experiencing a health disparity due to the obstruction to their care. And so providing care to optimize the wellness of these youth is actually a component of justice, um, where the cause of the inequality is addressed and the systemic barrier has been removed. This barrier being the obstruction to gender affirming care. So, before you think that this is me going on a wing tangent and sort of coming up with a total political view on this, um, I subscribe to the same mentality as a lot of medical associations that promote gender affirming care. Such as the American Medical Association, the American Academy of Family Practice, the American Academy of Pediatrics, the American Psychological Association, the American Endocrine Society. And not only do they support gender affirming care, there are now clinical practice guidelines that have come out to help providers manage gender affirming care. This one comes from the Endocrine Society. It's the Endocrine Treatment of Gender Dysphoric and Gender Incongruent Persons and Endocrine Society Clinical Practice Guideline. Um, and uh, this wasn't too long ago. I want to say it's at least 2 to 3 years of since it's been published. So um, I am choosing to go through this as a case um, presentation first, just to give you an idea of what the common approach is to gender affirming care. Um, with all these sort of bans on gender affirming care, it's good to know what happens. So my job isn't to tell you, to support or to object, but you should know exactly what you're objecting against. Um, and so let's start with the first case. Yeah. So A um, is a 5-year-old natal male, which means he was born or assigned male at birth. A's parents notes that he mostly plays with girls. He does not want to play sports except volleyball. He likes to wear his mother's high heels. He asks if he can wear makeup. All right. And so um, in case one, patient A, um, what is your initial reaction? Right. Are you concerned? Should his parents be concerned? Oftentimes, when people are confronted with transgender patients, within the last couple of years, I think they're they're starting to um, uh, be more forward or more comfortable with presenting themselves into sort of general medicine. And so more and more patients, oh, sorry, more and more providers and physicians are being exposed to transgender patients. And so it's good to sort of do this check before, you see patients. Like, what what is your initial bias or instinct when you read about the case? And what things do you need to think about as their advocate to their care? So in the first appointment, whether or not it's a pediatric patient, if I'm dealing with an adult or a pediatric patient, there are some set of things that I generally get, and what I call the first appointment the tel leva, which is basically getting the boat or getting things ready. To it's a Samoan term for getting the field ready. And I understand that patients and their parents come to me very um, anxious. You know, um, they're expecting judgment a lot of times in regards to their family member. Um, and so it's really, really important for me to keep those lines of communication open. And so it's extremely important for me to establish trust on the first visit. um, I obtained a medical history. I tried to use non-judgmental language. We discussed the term gender dysphoria, although there's other terms that we are using, and we'll talk about those later. We talk about sort of what their goals of treatment are, or what the goals of the visit are. What are they trying to establish? We go over some family history, um, social history. We go over some social determinants. And usually, this is the social determinants are generally the support they have when it's a child. Like, what supports do parents have in regards to raising their children? Where does the gender dysphoria tend to cause problems in their lives? um, I also screen for eating disorders. It's not uncommon for transgender patients to develop an eating disorder in the adolescent age. We talk about domestic violence in the home. We'll ask also for older patients. Sexual history, employment history, and then for all patients, we want to make sure they get immunizations or immunization history. Um, and then one of the things that we often do on the first visit is to define terms. And one of the terms that we have to make sure parents have thought about and have usually a good understanding of it throughout their time with us is, can they define gender, right? And so there are different terms regarding gender that we use. We use assigned gender. We use sex at birth. These are generally the sex that's assigned at birth, which is largely based on anatomy. Um, we have gender identity. This is the understanding of how one identifies. And it can run the spectrum of female, male, transgender, gender nonconforming, gender queer, non-binary, gender fluid, and cisgender. And I will tell you that's not all of the gender identity categories. And then there's also gender expression, ways in which a person acts, presents themselves, communicates gender within sort of the norms of a given culture. And so I oftentimes will um, introduce terminology so that parents can be more comfortable using them, but also so that they don't need to stumble on how to identify different categories of gender. And so we go over what cisgender generally means. One who identifies and aligns with the cultural notions of gender with the sex they were assigned at birth. Transgender is a person who does not do that. Um, and usually does not fit the conventional notions of gender um, in their cultural context. And then there's gender diverse, non-conforming, non-binary, gender queer, gender fluid. These are persons who view gender on a spectrum, and so they don't fit cleanly into cisgender or transgender. And so these categories are generally used for those who fall into that situation. Um, and then there's defining sexuality. Um, and so there's sexual orientation. That's based on one's feelings, attractions, and desires. Sexual orientation is then later defined into discrete categories like lesbian, gay, bisexual, transgender, questioning, queer, pansexual, and asexual. And I will tell you, these are not even close to being comprehensive to all the sexual orientation identities. And then what those particular identities mean in regards to behaviors. Um, and I make it really, really clear to parents that sexuality describes how one identifies and how they identify those they are attracted to. We do not need to know anything about child sexuality to address gender dysmorphia. Um, Gender identity and sexual orientation are two completely different things. As whereas gender identity is something that is appropriate to evaluate in children. Um, Sexual orientation in pre-adolescent children is not. And so we make sure parents understand that because sometimes they don't, and confusing the two makes it more difficult to one find what the goals of therapy are when it comes to gender identity care. Uh, and then sexual orientation identities. Um, uh, as just like the ones we talked about before, pansexual is those attracted to any sex or gender. Asexual is one who does not experience sexual attraction. And then queer is the umbrella term that includes many in the LGBT community, but also people who fit outside the social norms of sexual identity, gender expression. So, case one, patient A, questions to explore. How does your child feel about their gender? Um, does your child feel and act more masculine or feminine? What does your child prefer to be called? What do parents of a child understand about gender? And how does your child feel about your concerns regarding their gender? And so these questions I leave them very open. Um, for parents to discuss. Make it very clear that it's a non-judgmental space. That not only is it important to evaluate, it's also important for them to understand and learn more. Because once the visit is over, you send this family home, and the more you equip the family to deal with the experience they're experiencing, um, the more you've been able to sort of help their care. So In pediatric patients, it's good to know what the milestones are for awareness of gender identity. And so the conscious physical differences between the sexes usually happens between ages 1 and 2. This is when they'll sort of tell the difference between men and women and boys and girls. Um, they may not be able to sort of articulate it, but they recognize it. And then at around 3 is when children usually can label themselves as a girl or a boy. They're able to say, with um, definitiveness, that I'm a boy or I'm a girl. By age 4, their gender identity is usually stable, and that's usually for cisgender patients. And they recognize that gender is constant. That usually people don't flip. You know, so it isn't that big of a shock that this patient presents at 5. Um, and so this is a survey they did on middle school students, um, uh, looking at their sexual orientation and gender identity. And so you can see here, um, in like almost a million kids, um, about 1.7% identified as gay and lesbian. About 2% were identified as bisexual. 12% was not sure. And then when it came to gender identity, about 1.3% identified as transgender. Uh, and so, um, although you don't see it that often, it exists, and it exists at 1%, which is pretty large. And then how many adults identifies as LGBT in the U.S. Just to give you a context. So there's about 3.4% of women identify, um, and 3.6% of men um, uh, identify as either gay or bisexual. And then 0.3% of the population identify as transgender. Mind you, these numbers are from 2012. Um, and the social context of these surveys may have changed in the last 10 years since they've done the survey, especially since other identities regarding non-conforming gender has come about. So these numbers may look different now. Coming out of transgender, and so the mean age of presentation for transgender patients is around 15, although the range is 4 to 20 um, for all patients. For females assigned at birth is 15.2, 15 years. And then for males assigned males at birth, it's about 14. And so um, this is an advanced Tanner stage. So Tanner stage is kind of these are the developmental stages of puberty. And so there's different uh, criteria for different stages of Tanner. But Tanner 5 is pretty much a full-fledged adult. So you can see here at 4, you're getting up to be really close to presenting at a full adult. Same thing with um, assigned males. Um, they seem to present at uh, a junior high-ish Tanner stage. So at 3.6, they have secondary characteristics that have developed, um, but are early. And so this actually has a huge implication in how you proceed, right? And so um, It's also good to know that there's different types of transitions. Social transitions usually is with how people transition with their friends, their families, um, and generally, assistance with social workers and psychologists, therapists, and counselors are generally needed for social transition. Medical transition is usually in the field in the wheelhouse of physicians and nurse practitioners, and then we have legal transition, which is sorry, medical is more biological transition, and then legal is changing things like your license or your passport or the name on your professional documents and certifications. And usually, this is something that you need the help of a lawyer. Um, there are some pretty amazing Pacific Islander community groups that are now helping with transition, the Mapumaya Clinic being one of them. Um, and then so it's always important to understand that gender affirming care usually is best done with a multidisciplinary team that assists the patient in different aspects of their transition. So a lot of the common parental complaints that you'll get um, for patients who are gender nonconforming um, is before puberty, things like she told me in the first grade that she was a boy. He wanted to grow his hair long and wear jewelry. She adamantly refused to wear a dress to her aunt's wedding. He wanted to be in the school play in the role of Cinderella. And then there's things after, well, in the middle of puberty or peripubertal, things like we didn't notice anything different before puberty. She had a miserable time with puberty. Before puberty, we thought maybe he was gay, but then he told us he was trans. And so all of these should raise the concern that you're dealing with a patient that has gender nonconformity issues. Um, issues is the wrong word. Is dealing with gender nonconformity. And so it's important to sort of not dismiss these but to acknowledge to parents that these cases do happen. And then we'll talk about how to screen, right? And so, um, really, it's whenever you're doing your developmental stages. So, to the pediatricians that are in the uh, to the pediatricians that are in our happy group, but also within the audience that are watching, um, any child that sort of expresses non-conforming behavior should be screened. It doesn't mean that you're going to actively treat at that time. It just means it's on your list of things to monitor. Um, um, and then be very careful to monitor for things that may not be that obvious when dealing with a non-conforming expression. Do they have a change in mood? Do they have a problem with their behavior? Is there a problem? Are they socially awkward in a lot of situations? So, how to screen? Um, and so, I generally like to ask questions that don't appear to be that pointed. you know Things like, oh, what do they like to do, what do they like to play with, um you know what do they like to wear, what clothes are they into, and then ask parents, are you concerned with their choices, um and then ask whether or not, how are they doing at school, um you know do are there concerns with their behavior, do they have friends, are they not doing well in school, are they dealing with bullying, um, you know do they sense that their child is dealing with any kind of anger, sadness, or feeling isolated, and then things I ask my patient is are things that are generally more direct. Oftentimes people get a little skittish asking pediatric patients these questions, um, but um, when it's done in a very non-judgmental way, children tend to be a lot more freer to answer these questions. Do you feel more like a girl, boy, neither or both? Um, how would you like to play? How do you like to cut your hair? What kind of clothes do you like wearing? Um, and then what name or pronoun? Like what name fits you? Like not what name do you want to be called or what name, because there's a lot of judgment in what name do you want. And so oftentimes we kind of slide around the question by asking, what do you think fits more for you? What pronoun fits better with you? Um, and so with our patient, A reports that sometimes he wishes he was a girl, but prefers the pronoun he. Um, he's sad that his mother seems to be upset um, by his behavior. Um, he's unsure what gender he would be if he could choose. Um, and he would like to play with girl things without feeling bad. Okay. So what do you do next? Well, for me, I explained to A and their parents that exploring gender roles and gender expression during childhood is actually really common. Um, A may or may not have gender identity concerns as they mature. And we can continue the evaluation as time goes on to see if they meet criteria. And um, it is all really, really, really important that um, they understand how important it is for families to be supportive. Um, you offer yourself as a resource, which means you go to talks like this and get yourself more familiarized with the topic, but also know when you're out of your depth. When do you need to bring in other resources, both local and national, to sort of help your patient. And so this is sort of a switch in approach, or sorry, terminology. And I should say, it's really, really important that we understand how impactful terminology can be. Um, you know, Homosexuality was considered a uh, certifiable psychological condition. So the DSM-4 had criteria which based the homosexuality as a pathological deviance of human sexuality. Now, since that time, the DSM-4 has been completely um, revamped, and they've struck down sort of the DSM-4 criteria. Um, but what it signaled was a change in attitudes towards homosexuality. And so the term gender dysphoria, although is descriptive on certain terms, um, is very pathology based. Uh, it can mark the difference of how one expresses and the experience they have with the gender and the genders others would assign them. Um, you know, it has to be persistent for at least 6 months and cause clinically significant distress or impairment. And in children, the desire to be of the other gender must be present and verbalized. Now, another option in sort of identifying these children who are non-conforming is using the gender diversity ICD-10 code. Um, the way it looks at it is that gender is universal, it's normal. There are variances expected as an aspect of biology and human development. Diversity does not equal deviance. Gender diversity can improve the care because it's not pathology based. Um, it can impact minority stress, and it's another form of reproductive justice. And it helps, with empowering a vulnerable population by taking the pathology based away from their condition and understanding that it's more patient centered. Um, when we're talking about gender affirming medical treatment, we're generally talking about pubertal blockers. And so the most common pubertal blocker that we use is called Lupron, and it can be given monthly to once every 3 months as an IM injection. There are other types of Leuprolide injections that change in different types of duration um, that last longer. And then there's Suprelin, which is a um, surgical implant that's placed annually. Um, and a lot of publicity has gone into that these pubertal blockers are new and we don't know what to expect from them. But that's just not true. We've been using pubertal blockers in treatment for a long, long time. Besides being one of the mainstay for treatments for prostate cancer, we've used it in a condition in kids called precocious puberty, which is when patients go into puberty too early. And they've been very, very safe in that population. They're also reversible. When you stop the um, pubertal blockade or the hormonal blockade, usually gonadal function returns. Um, but probably the thing that most people don't understand about pubertal blockers is that in this population, it's life saving. Um, so here's a study that looked at um, pubertal blockade in patients, and it was a small study. You know, there was like 54 patients, um, and these patients were underwent early blocking of puberty, so they're a lot younger. um, Followed by cross-gender hormone replacement, which means they went on to get hormone therapy for the gender they identified with. Out of the 54 patients they looked at, no patients decided to stop GnRH agonist therapy. Um, all patients who were eligible decided to take cross-gender hormones. So a lot of these patients just went ahead with the complete transition, and there were no adverse events from these GRNH agonists, um, the gonadotropin releasing hormone agonists such as leuprolide. And out of this group, there were no suicides, and none of them got their hormones illegally. Now, it's a small group study, so it's hard to infer a lot from it out of 54 patients. But one of the things that's really important to understand is that um, the reason why I think there was all the patients that were eligible went on to take hormones to transition was that a lot of the work that goes into this, finding out whether a patient has um, is wants to undergo gender diversity procedures um, and therapy. A lot of the um, evaluating and confirming gender nonconformity, gender dysphoria. Um, a lot of that happens throughout their treatment when they're younger. And so by the time they're ready to undergo transition therapy, you know, a lot of years have passed for them to make up their mind. And so these are not patients that and families that take this lightly, that decide one morning they want to be a different gender. This takes painstaking commitment over years um, uh, to continue to the transition. So this is the Trans Youth Project. Um, this was they use the NIH patient reported outcome measurement information system. um, and what they looked at was symptoms of depression in patients who underwent uh, hormonal blockade. Um, and what they noted from that was there are symptoms of depression and anxiety during the past week, was that they didn't have much more depression and anxiety compared to other children that was their same age and gender. Um, and they were significantly lower than patients or gender nonconforming children that weren't going through treatment. And so you know, it's the conclusion was that um, uh, socially transitioned children who are supported have developmentally normative levels of depression, and they have some anxiety, but it's just a slight increase. Um, but what it means is that this psychopathology, the anxiety and depression within this group is not inherent in their identity as being transgender. Um, what was really striking was that children with gender dysmorphia um, uh, had higher rates of these psychopathological conditions compared to children that were supported, and so it makes a huge difference because we talked about how, you know, we have rates of about 80% considered suicide and about 50% had even attempted. And so this family acceptance project was a study that looked at about 245 um, um, LGBT young people. And what they showed was that with family acceptance, um, you know, patients were more likely to have higher self esteem. They had strong social support, and their general health status was good. And what that protects against are things like depression and suicide, substance use, and suicidality. Um, and so um, this social support that we talk about is one of the social determinants of health, which is conditions that we undergo that has a huge impact on our quality of life and our health and our functioning. And so, right there under the five categories of the social determinants of health lies social and community context. And so, we have a lot of strong Pacific Islander um, LGBTQ plus advocacy groups. And currently, they're doing a national and a California survey. And you know, the queer and trans Pacific Islanders have to deal what all NHPI communities have to deal with, which includes racism, xenophobia, classism, and these leads to obstacles in education, healthcare access, and economic equity. But more so, on top of that, is that queer and trans Pacific Islanders also have to deal with homophobia and transphobia. And these lead to alienation, which leads to higher incidence of depression and drug use and unemployment, which is what our preliminary results are showing. Um, and so, out of this, the advocacy groups are working to make up the men's and show that there is a ample amount of community support when it comes to queer and trans Pacific Islander, and especially trans or gender affirming care. Um, the Mapumaya Clinic, which just opened, is providing gender affirming care to a lot of Pacific Islanders. Um, and they're also providing overall wellness of care through their medical facility. Um, Knowing that there's a large percentage of trans and queer Pacific Islanders that um, are sex workers, um, they also have outreach into those sex worker empowerment initiatives, um, as well as like serving the community at large. um, and so when we're dealing with equity at this level, uh, not only do we provide justice in the form of gender affirming care, but when we're able to do it for our people, then we are included, in this sort of grand scheme of America, if you will. So some quick things that you can do in regards to changing your environment as a provider. I added this to this slide, so I talked about this on our previous talk, so I won't spend too much time on it. But signage, providing gender-neutral bathrooms, also making sure that there are safe places for the staff and patients to learn about gender-affirming care, and then language, right? What pronouns do you use? Avoid terms, sentences like identifies as trans male, um, but rather, so and so is a trans male. Don't forget the dead name means that it's the birth name of someone who has changed their gender or their name as part of their social transition. And then electronic records should have their patient's pronouns. Um, as far as our Pacifica ground rounds go, and these are the last couple slides, we just did our second one. Just remember that it occurs every third Tuesday of the month at 5:30 p.m. U.S. Pacific time. You can send your topic suggestions either to the PBD Facebook page or to the Happy Doctors Gmail address. And then, as I said, this is a joint project with Mapumaya Clinic, the Healing Association of Pacific Islander Doctors, and Pacifica by Design. This is a list of the upcoming topics. So in August, Dr. Jana Dichter, um, you might know her. She made her rounds on the talk shows. Um, we were able to do a transplant, bone marrow transplant for a patient, which cured his HIV. Um, and then Raul Jandil is going to speak about head concussions on our athletes. And then we have our superstar Kiko Tapara, who will talk about structural racism and NHP oncology data. But there's a whole host of topics and more to be confirmed. And so take a look. The topics are all going to be on the Happy website for you to peruse. And we also will have the talks recorded um, and put on the Pacifica by Design YouTube channel. So you'll be able to access the talks there. Um, we are working on getting CME credits for the grand rounds, which means that we'll probably be putting out evaluations as part of that process. And that's it. Thank you so much. So we're going to transition over to our Q&A session, led by our host with the most, Carl.
Hello, hello. So we didn't have questions in the chat, but since we have everybody here, it's probably a good time to have a conversation. And I think that as we were going through today, one of the questions that I had in mind was, as we because their genders and those kind of things were part of our culture prior to Europeans landing. Do you see hesitancy to engage in these kind of things in our culture, or do you feel like this is, I guess, being received well? And that would go to anybody.
Wait, say that again, Carl.
How is so you're reaching out to the community and you're providing information and knowledge. How is that received from our people? A lot of times our people are more likely to listen to faces that are on the screen, not mine, but yours, people that look like them, right? People that are in the community. Do you think it would be harder or even possible for doctors that don't look like you and Keiko and Kalani to hold this conversation with people in our community?
That's a good question. I have a response, but I'll let my colleagues go first. I'm just going to steal your answers, so go first.
I guess is your question like, how do you think Pacific Islander communities are accepting of gender affirming care? Is that your question, Carl?
Yeah, in a nutshell, that's like how receptive is the community, um, that really what the mainstream isn't necessarily PBD is geared towards Pacific Islanders. So how receptive is specifically the Pasifika community, um, to the gender affirming care?
I can give it a shot. I'll just speak from my own personal, my ohana and my perspective from my lived experience. But I think that a lot of us have, and within my generation in particular, have kind of forgotten our roots and forgotten our past. And so I'm not actually sure how much that necessarily influences the receptivity of it. But I think once we do realize, our deep roots and kind of how progressive our society was back then, I think that it ultimately does become very accepted. And within my own ohana, I have twin cousins who have transitioned. They actually went much through their young adult lives not telling each other that they wanted to transition, and they are transgender men. And they independently came up with this. And I think that there are definitely, even within my own ohana, uh, challenges, but I think that my cousin, I'm so proud of them. I think that they've opened up so much, mana'o from their own lived experiences to me and my grandparents and aunties and uncles. So I think it's always just about a conversation, even within our like my native Hawaiian family, it's just been a conversation. But I'm just very, very proud of my cousins to kind of having started that conversation and trying to be true to who they are. So that's kind of where I'm coming from.
I think you bring up a great point, Kikoa, of the lechi, the mahu, the fafafine, like in a progressive in the sense of that was a long time ago, but then we're more returning to having that be accepted. So I think that's you know a really strong point, and it's a conversation, right? It's to your point. It's let's just have the conversation and be open to talk about it. How about yourself, Kalani?
No, I mean, I think I have a similar perspective. I think things are changing in, a more receptive direction over the past sort of 20 years, back to sort of the identities that were more familiar, to our ancestors. And so, I think that's a really positive move forward in that direction, obviously. Yeah. But, like Ikoa said, even within a family, there can be a lot of differences in opinions about how people, receive it. So it's not strictly about, you know, your upbringing, but, maybe your political leanings or, you know, the potentially, your connection to religion and religious leaders and that sort of thing can be impactful as well. Yeah.
Dr. Samoa, do you find the conversation easy to approach, or
Wait,
is it?
wait. How come you call Kikoa and Kalani by their first names, and then I don't appreciate that. Um, I think I'll liken it to the Mauna Kea protests. I think there was on the ground level still a lot of transphobia, some homophobia that was accepted and within the community. Um, but when Kumuhina started to chant and lead like some of that movement, it it started to harken people back to, um, you know, how leadership doesn't always fit the gender norms of Western society, and I think like having that kind of visibility, that was the face of the Mauna Kea protest, was one of those things that you had to reconcile. It was like, look, you can't have people that are for your community within your community, and then talk about them. You know, and I think the more we have discussions about it, the more we can normalize sort of talking about those roots, because maybe not in Hawaiian, but like definitely in Samoan communities, we definitely have um, some problem, not problem, let's say, but like we have a tendency to mix cultural and our religious identities, and they tend to blend into each other. And so our idea of the binary, the idea of traditional gender roles, come more from that religious identity, more so than the cultural identity. And I think like the more we have these conversations, the more we talk about them, the more we can get to, sort of separating those identities, because it's, you know, um, that's why I'm really kind of proud of these community-based organizations, because when COVID was at its worst, they were hustling. You know, you'd be hard pressed to find any of the community-based organizations that was reaching out to Pacific Islander communities that didn't have some type of queer leadership. You know, I would say that they existed, but they're definitely the minority. And so as they become more visible, we have to start talking about where we like why is it that we uphold the binary and gender roles so vehemently? Like, what is it? What do we benefit from it? You know. And so yeah, like the this
I guess
talk and then the touch before, I think that's one way to sort of kick people into a direction of at least having a conversation.
yeah, I think that's kind of cultural in the piece of like, let's talk about it. Let's let's discuss it. Let's talk about it before as we move it forward. Listening to the presentation this evening, it really struck me of the like there's a piece of mental health um, in the gender affirming care. Like when you're teaching a parent like how to recognize a fever, how to recognize a cold, how to recognize these things, it's almost like second nature, right? Like I know I need to take care of my child, and these are the kind of things I need to do. But you're talking about other things like being able to recognize like how people are expressing their gender, the difference between gender identity and gender expression. Do you find yourself, and this is for anybody, being almost like a balance between a kind of almost a mental health conversation when you're talking to parents about this? Because it doesn't seem to me like it's as easy as lift up your tongue. I'm going to put a thermometer underneath your tongue, and then we're going to read it, and it's going to read a certain number, and I'm going to say fever or not a fever. It just seems like way more involved with that. How do you navigate that discussion, I guess? And Ray, we'll start with Kalani.
Well,
Okay.
actually, my question was for Ray. I mean, it was kind of, I mean, it's very much along this line, and maybe it starts with a comment, but, when I think the lay public hears the terminology gender affirming care, like all they think about is giving medications to transition someone's gender, right? But as you outlined in your talk, and I hope that the audience appreciates, a lot of this is really social, sort of nurturing, family counseling. You touched on like the importance of having mental health providers, and the medications and surgeries, if those are involved. I mean, obviously those are big components of therapy, but I mean, it's not the whole thing. So much of what goes into it, and I don't provide gender affirming care, but I do see patients who have transitioned because you know they get kidney disease too, just
Right.
like everybody else, you know. But I guess my question for you, Ray, and Carl, I'm not even really answering your question, but uh, like how many, what proportion of people that come to you proceed with transitioning, and then like what is kind of the average time from first consultation to yes, we are going to do this with medication therapy?
It's strange because I don't see that many children. Like I would say I see less than about a handful a year. But 5 years ago I saw none, right? And I think it's that whole finding somebody you trust,
Yep.
and so I think what these families are doing is everyone's in the community is referring who they go to. And so that's where these, and like once you establish yourself to um, a subgroup of patients, expect that more are going to come follow, that are going to follow you. The more gender affirming care you provide, it's kind of like Samoans, right? And Hawaiians too. When they hear of like a doctor that's good to Samoans or Hawaiians, guess who's going to be guess who's going to be on the doorstep. Um, and so the ones that I see, I would say um, two. Like two have transitioned. Um, a lot of times, they wait. You know, it's a very common thing sometimes for um, the patients I see to wait till like they're 18. Like that whole thing of I'm gonna go to college where I'm my own person and I don't have to like deal with the people I grew up with or the people that I've seen
Mm.
before. I'm gonna take this new identity and I'm gonna run with it. Um, what gets really problematic though is when you know the study I showed you, where you know the huge difference between kids who are supported by their family and the kids who are not. Um, that plays a huge role. And I think a lot of times with the patients I see, the family support isn't 100, it's 80. And so any type of hesitancy tends to make children wait longer, right? You know, a lot of times with Pacific Islander children that are non-conforming, people think they do it out of rebellion. They think that their gender expression is because they're trying to fight against their parents' control, when actually the opposite happens. Most of the times when I talk to individuals, you know, that are trans in our community, they hate the fact that they're, at least at some developmental stage, they hate the fact that they're hurting their family. You know, eventually, hopefully, they mature enough to realize that it's not their fault. Like, but that rooted in a lot of their sort of rebellious behavior when they not rebellious, but as they get up and they do, um, uh, things that look more rebellious, it's because they're kind of funneled in that direction. Um, and so the if what I often tell families who just cannot be supportive is to find support for their kid. You know, They're I have yet to see a Pacific Islander family that's 100% transphobic. You know, there's always support somewhere in the extended family. There's always, there's support um, within the community. That's starting to be more vocal. Like Utopia has chapters in Washington, Las Vegas, Alaska, LA, Portland. So connecting to these groups, will show where these kids can go and learn how to grow up trans, learn how to grow up gay and lesbian. Because if you don't teach them in your community, they're going to go on the street and learn it, right? And they're going to learn a lot of destructive behaviors from people who don't care about them. I don't think I answered your question at all, but I'm just going to act like I did.
Sounded very eloquent the way that you didn't answer that. No, I think it's a good point, though. I mean, I would think that if my gender expression were taken as not genuine, right, it's just me being rebellious, that would compound that could compound an issue. Right now, I'm trying to be my true self, and people are thinking it's just me acting out. It's not me actually being me, but um do you find that because you're talking about ages, the ages that you were going through and asking, the questions of how people are how the child is acting and expressing themselves and those kind of things. Do you think that's hard for a parent to recognize, I guess, to ask those kind of questions and to
Yeah.
especially, being a parent, just getting the kid fed and get the diaper changed is hard sometimes. But to see those things, it seems like it is a not an uphill battle, but it is a very much an awareness issue as to, what you're seeing your kid do at a certain age, certain stage.
Yeah. I'll tell you why. I'll tell you why it's scary. So the narrative that we have been grown up with when it comes to queer and trans kids is they'll grow up lonely, they'll die alone, you know, and they'll be bullied, right? Nobody wants that for their kids. You know what I mean? Like it's and so I when you see it, for a lot of parents, it's almost like a death sentence, right? Like they're looking at their kids and this whole idea of what um uh the milestones of life that they're supposed to enjoy through their kids, like their kids supposed to grow up and fall in love, have kids, get married. All of a sudden that story ends in elementary school, right? And you can see how like parents um don't want to give that dream up, you know. But it ends up hurting, when um you don't when you hold on tighter to the dream than the kid in front of you, you're going to lose both. And so that, yeah, that's something that we have to teach each other too, right? Like we have to teach each other that just because you're queer trans-Pacific Islander doesn't mean you're going to be alone. It doesn't mean that you cannot have a family. It doesn't mean you can't succeed in education. I think like the new visibility, um, like the Samoan prime minister, you know, Fiame, also like the um, the number of Samoan female matais that are coming out now with high name matais, not like just the low level title. There's some like big hitting matai names out there that are now occupied by women, and that visibility is so really important because it fights against gender stereotypes. Um, you know, just like I'm equally as proud of Ian Dongi as I am of Sasha Kobe, you know,
Hmm.
because to me they excel. They're both excelling. One does it within a accepted sort of gender conforming way, and one does it in a gender non-conforming way. And so both of them deserve our admiration.
I think you're right with the what are the images, right? What are the images that we see? Um, and big discussion. And so Keikoa, you can see the gray here. Dr. Samoa has it as well. But it's good having these conversations, right? So hopefully, later on in your career, when
Right.
you're having a conversation with the next generation, how far forward do we come? Go ahead, Doc. I'm
Oh,
sorry.
let
Go
me
ahead,
just
Ray.
introduce Kiko Atapara because we didn't introduce him to the
Okay.
public. We introduced him to our backstage crew, but Kiko Atapara is a radiation oncology fellow, who's native Hawaiian, who's training at Stanford, and he's currently in his research year. Um, Kikoa Tapara is nothing short of a rock star in our community. And I say this as somebody who shepherds Pacific Islander physicians. Kikoa's um, is unbelievable advocate and researcher, and he answers my emails. So I'm a huge fan.
That's how you become a favorite. You answer.
You answer my email, and no, actually, Kikoa, you want to say hi?
Yeah, mahalo, Dr. Samoa, and aloha, everyone. So glad to be here. And yeah, I focus on oncology. Very passionate about Pacific Islander health. And if anyone ever needs to get in touch with me, I'm very active on Twitter. But yeah, just always trying to learn as much as I can about, especially our other cousins who, we don't really get to talk about as much. Not just the Polynesians, but Micronesian, Melanesian cousins. We have so many out there that we can all learn from. So really great to be here.
Yes, it's good to say that. We're still looking for our Melanesian Pacific Islander physicians. So if you know them, please refer them to us. We do have a nice lineup of speakers that come from Happy and also from outside of Happy to present topics that we've been asked to present. So I'm looking forward to the rest of the series. Yeah.
Definitely. Definitely. We're just getting it off the ground. So thank you both for the time, great information that you shared with us, and we'll definitely need to have another show to cover more. And I can see in the pre-show, um, uh, Kalani was saying things about Keikoa, and Keikoa is being very humble. So we're gonna have another show to have Keikoa back on and get more of his opinion. But thank you so much, both, for being on, sharing the information, and we will see you on the next round of Pasifika Grand Rounds.
All right.